Okay, I'm going to begin by asking you a question, and this is from something that you did when you were doing the cardiovascular system, okay? So you learned about this hormone. So we've really started learning about hormones way before this actual system. So there was this hormone erythropoietin which was produced by the kidneys. And what is the function of this hormone? Okay, I'm not going to tell you the answer, but we'll go to the next slide and then we'll see how many of you got this correct. So here, these are the organs which we studied the endocrine system under. So beginning from the brain, so right up on the top is the hypothalamus, which truly speaking is the master gland. Initially the pituitary was called the master gland, but actually it's the hypothalamus which is the master gland, because it directs the pituitary to do its job, and then the pituitary acts on various other hormones. So really now the master gland is the hypothalamus. Then we have the pituitary, also seen in the brain. Then when we come down, the thyroid and the parathyroid glands. The parathyroid are really sitting on the posterior aspect of the thyroid, so this is present in the neck. Then pancreas in the abdomen. The pancreas have both an exocrine and endocrine function. And we'll look at the exocrine part in the digestive system. We are looking at the endocrine part here. The ovaries and testes, we won't do the ovaries and testes now. We'll do them when we do the reproductive system, but they are still part of the endocrine system. Thymus, you already did the thymus when we were doing the lymphatic and immune system. Remember how it produced thymoxin, thymopoietin, and all of those, thymosin. So these are endocrine hormones which are produced by the thymus and allowing the thymus to do its job, which is to make T lymphocytes immunocompetent. We will study the pineal gland, which is also present in the brain, a very, very important gland. And then we look at certain cells which are present in organs. You have done most of them. In the heart, in the walls of the atria, there was a hormone which was produced. Does anybody remember what that hormone was called? In the walls of the atria. No? Nobody? Does this ring a bell? Tell me, it's vaguely familiar? Vague, okay, right? So this stands for atrial natriuretic peptide, right? You remember that? Okay? As the name suggests, natrium, what does natrium tell you? What is natrium? Pardon? What's that? Natural? No. Natrium, it's the symbol for one of the elements comes from the word natrium. What is this the symbol for? Sodium. Sodium, actually, you get Na. Why, it should have been SO, isn't it? If we look at the first two. But it's not. It comes from the word natrium. And that's why you have Na. So natrium is for sodium. Uretic means to remove in urine. So natriuretic is removing sodium in the urine. So you can see that the function right from here, you get to know the function of ANP is to remove sodium from the body and remove sodium in the urine. So natriuretic, and with sodium actually water also goes out. And this is one of the hormones which is produced by the heart, and it helps to actually reduce blood pressure. Because if you remove sodium and water from the body, what are you doing to the blood volume? You're making the blood volume less, and the blood volume becomes less, your blood pressure will also become less, right? So it kind of helps. In the kidney, erythropoietin was the hormone which was produced. Erythropoietin is important for erythropoiesis. Erythropoiesis means production of erythrocytes. Erythrocytes are red blood cells. So 88% of the class got this right. I'm glad you remember. So it is important for production of red blood cells. Production of white blood cells is through something produced in the bone marrow called leukopoietin, and for platelets you have something produced by the liver called thrombopoietin. Okay, so these are again hormones produced by different areas, discrete cells. Adipose tissue also produces hormones which are important. So you can see that within the cells, within organs or within tissues, you have these discrete cells. So it's not a complete endocrine organ by itself, but you have these discrete cells which produce hormones. And what exactly are hormones? These are chemicals which are secreted into blood in small quantities. They pass through blood, so that's why we call endocrine glands, actually we call them ductless glands, because the hormones are secreted directly into blood. These glands do not have ducts. Glands do not have any ducts, so that's why these endocrine glands are often known as ductless glands. Exocrine glands, on the other hand, if you compared exocrine and endocrine glands, so if you look at an exocrine gland, let's say take a gland in the, or even let's say take the pancreas. So if you look at the pancreas like this, the pancreas is made up of an exocrine part. So these are the cells which produce the secretion or enzymes, which are poured into ducts, and this duct actually leads into the duodenum. So you can see it reaches the lumen of where its target tissue by means of a duct. When you look at endocrine glands, if these are the parts which secrete the cell, then there's no duct. So what happens is that the gland produces hormones which will pass into the interstitial space and go directly into blood. Through blood, they go to distant target organs. Exocrine act at that point. Endocrine go to distant target organs for most part, okay? No ducts present. So these may be steroidal in nature. So for example, in the adrenal cortex, you have hormones which we'll see like cortisol, which is produced, which is steroidal in nature, or hormones may be protein in nature, or they may even be lipid in nature. There's a hormone called prostaglandin produced by prostate. It's also produced by the cervix. These prostaglandins tend to act locally. So they don't go by blood to distant target organs, but they act locally. So few hormones are produced which do not go to distant areas, but they just produce locally. Prostaglandin is one such example. So that's why I have it in italics. In order for the organ where it goes, in order for that organ to act, that organ must have a receptor sitting on it. Very similar to you did receptors. Remember when we did the immune system, right? And we were talking about lymphocytes, and we said when an antigen comes in, the lymphocyte should have a receptor in order to react with that antigen. Same way, the organ on which the hormone is supposed to act, that organ must have a receptor on it, because otherwise that hormone will act on all the cells in the body, right? So only those cells which have the receptor will be able to be affected by the hormone. The response does not occur immediately. In the nervous system, for example, again, you have neurotransmitters which are produced. They act on either a muscle or on another nerve cell, and the response is really fast. In the case of the endocrine system, first the gland has to produce the hormone. Then the hormone has to go through blood and then go to the receptor. Then it has to attach to the receptor. So it takes some time for the action to be seen, and that's what is meant by lag period. That means it's not immediate. So it takes some time, but the effect lasts much longer. In the nervous system, the action occurs really fast, but it also wears off very fast. So very often we call the endocrine system like the slow snail mail system, whereas we call the nervous system the really fast express train kind of system. So here the response may be just for minutes if that's what is needed, or it may last for days. So the body kind of responds based on how homeostasis needs to be maintained. How do these hormones actually act? What they do is they alter membrane permeability, allow substances to pass in and pass out, so that might be one way. Or they might enhance protein synthesis within the particular cell that they're acting on. In some parts, they may activate or deactivate enzymes, so that's also important. Then they may even trigger secretory activity, so we'll see that one hormone may act on another gland and cause that other gland secretion to increase, so that's how secretory activity may be triggered. Or they may help in mitosis, so cell division may be enhanced. For example, growth hormone. It acts on the musculoskeletal system, which makes a person grow during the growing period, so it causes increased mitosis in the cells, okay? The action depends, of course, as we said, on the presence of the receptors, on the level of the circulating hormones. While hormones are not produced in excessive quantities, you always need an optimal level to be present. So if the level is low, then we call it hyposecretion. If the level is high, we call it hypersecretion. So based on if hyposecretion, obviously the action will be less. If there is hypersecretion, the action will be enhanced, and that's when disease processes will be seen in either one of these situations. The number of receptors, so that's obvious, the more the receptors, the better. And the affinity of the receptors. The affinity means the ability to interact well with the hormone. The affinity, how well the receptor can interact with the hormone. So for example, maybe there's a hormone which acts on the skeletal system and maybe it acts on the muscular system as well. But its action on the skeletal system may be more because the affinity of the receptors in the skeletal system is more. That means they interact better. Whereas the muscular system, the action may not be that much because the affinity is less. By knowing how these hormones act, we actually use it for clinical applications, and we can actually say how certain autoimmune diseases are produced in the body. So two examples that we will see, and you will do this. One is a condition known as Graves' disease. And when we did autoimmunity in the immune system, I mentioned this Graves' disease. This leads to hypersecretion of thyroid hormone. And it's an autoimmune condition. Normally in the body, when hormones are produced, as I said, they always have an optimal level. So the hormone starts from baseline, it reaches its optimal level, and then it's like a switch turns it off so that the level falls down, because otherwise it will keep on increasing. If you keep stimulating the cells to produce, the hormone levels will keep on increasing. You don't want that to happen. So when it reaches a certain level, the trigger which causes its stimulation goes off, so the hormone levels fall. When they fall below a certain level, again the trigger comes on and the hormone is produced. So you can see that it's produced in cycles. Now in Graves' disease, what happens is that there are antibodies which are produced, and these antibodies resemble something called thyroid stimulating hormone, or TSH for short. So if you understand here, you'll actually understand how the endocrine system works. As the name suggests, thyroid stimulating hormone. That means this hormone goes and stimulates the thyroid, and then the thyroid produces its thyroid hormones. So imagine here the trigger is TSH, which stimulates the thyroid to produce thyroid hormones. They reach an optimal level. TSH is switched off. So thyroid hormone level falls. When it falls to below normal level, then again TSH, kind of the trigger is stimulated, again thyroid hormones will be produced, and so on. These autoantibodies or antibodies against the gland, what happens is they resemble thyroid stimulating hormone, but they are not affected by that on-off switch. So with the result, they constantly stimulate the thyroid gland. When they keep stimulating the thyroid gland, what happens is that the thyroid hormone level goes on increasing like that. It keeps going up and up and up. So what happens is you end up with a hypersecretion state. Do you understand? It resembles thyroid stimulating hormone, but it is not controlled by the same on-off switch. So therefore, it just keeps on stimulating the gland, and the gland keeps on sort of secreting hormones. You get a hyper state. So this is one of the bases of autoimmunity. The other clinical application we can use is that when we know about the affinity of receptors and how they can interact with particular hormones, we use it for, one of the drugs we use is an abortifacient drug. And this abortifacient drug is known as RU486. It has a trade name, but it in Europe, it first came out in Europe and then the FDA approved it here. In order for the fetus to survive in the uterus, it is very important that progesterone is present. Progesterone is a very important hormone to make sure that the fetus grows and survives inside the uterus. So inside the uterus, you have these, in the uterus up here, you have these receptors, and progesterone comes and interacts with these receptors, and it makes sure that the uterus is prepared to receive the embryo, which will grow into the fetus, and it will maintain pregnancy. When you give RU486, what happens is it goes and sits on those receptors. So it also has affinity for those receptors. So it goes and sits on the receptors. So it already occupies them. So with the result, progesterone cannot attach to those receptors. So what happens? The embryo cannot attach properly, or if it's already attached, it will not embed properly and it will be shed. So that's how RU486 acts like an abortifacient, because we know that it has an affinity for these receptors much like progesterone. Okay, so that's how it acts. So such like this, there are many examples that we have in the body where we kind of use this knowledge of the affinity of the receptors, or we can explain autoimmunity or other conditions, or based on how many receptors they are present in that area. So let's take a look at some questions here. What do you think is the most important factor which determines whether a hormone will act on a particular target cell? Very good. Most of you got this right. Yes, the hormone must have receptors. It does not have to be steroidal because it could be proteinaceous, it could be lipid in nature. It doesn't have to be produced locally because only some hormones are produced locally. It also doesn't need to be produced in, the hormone must be produced in sufficient quantities for it to be able to perform its full action. But if the hormone is produced in sufficient quantity and the cell doesn't have receptors, then it will not act, right? So the most important feature is that the cell must have receptors in order for a hormone to act on a particular target cell. Let's look at this question. Why does the number and the affinity determine the action of the hormone? Good job. Yes, greater number and greater affinity means that the hormone will be attached better and hence produce a stronger action. Hormones do not necessarily want to act on all tissues of the body. They only need to act on whatever tissues they are responsible for. So I gave you an example, growth hormone. That hormone acts mainly on the musculoskeletal system. For example, thyroid hormone. Thyroid is one hormone which acts on pretty much all the body tissues. But let's say parathyroid hormone or calcitonin, another two hormones, they act for calcium metabolism. So they act on the kidneys and they act on bones. They don't need to act on adipose tissue or anything else. So you don't necessarily want the hormone to be distributed all over the body. You just want it to attach better so that it can produce a stronger action. Let's see how hormone secretion is controlled. So there are three ways that you can control it. Either it is something in the blood that causes the hormone to be produced. So either the level of something is very high or the level of something is very low, and that brings about an action. Or it could be a nervous stimulus which causes release of a hormone. Or it could be a chain reaction. One hormone acts to cause the production of another hormone, so it could be just one step, or it could be two step. One hormone causes the release of another, and that causes the release of another. So, like a two-step stage, okay? Why do we say something in blood causing production of a hormone to be humoral? It is because earlier when, long ago, when people discussed fluids in the body, they referred to all fluids as humors. So blood was a fluid, so it was called humor. You remember from ANP1, aqueous humor and vitreous humor? They were fluid or jelly-like substance, so that's how the word humor came from. So that's why anything in blood is known as humoral response. Now the way you should kind of understand this is always think of what is the action of the hormone. So let's say the action of a hormone is to raise the levels of calcium in the blood. So in other words, raise serum calcium. So think about it, when would that hormone be secreted? That hormone would be secreted when the level of calcium in the blood is low, right? So that if the level of calcium in the blood is low, then you secrete that hormone so that it can perform its action and it will raise serum calcium, okay? So this is the way you're going to think whenever you think of humoral stimulus. So let's look at an example. So here is one such example up here. This is the thyroid gland, and sitting on the posterior aspect of the thyroid gland are these four parathyroid glands, and their action is to raise serum calcium levels. So if, for example, the calcium levels in the blood become suddenly low, to whatever reason, that you're not having enough calcium in your diet, or there's some other problem going on, let's say you don't get enough vitamin D, so, vitamin D is very important for calcium absorption. So anything which makes calcium levels in blood become low causes that blood goes all over, it goes to the parathyroid glands where they sense that the level of calcium is low. So they secrete their hormone, which is called parathyroid hormone, or also known as parathormone. And this parathormone then goes and causes the bone to release calcium. It causes absorption of calcium from the kidney tubules. So then that gets thrown into the blood and your serum calcium rises, right? So you can see the stimulus was the low calcium levels in blood. So it was something in the blood. And the response was for parathyroid glands to act and release their hormone, which will go and act on bones and kidney tubules, cause calcium to be absorbed. That calcium will be thrown into the bloodstream. Calcium levels will rise. Then that stimulus will go away and parathyroid hormone will no longer be secreted. Yeah, you had a question? Hypersecretion, not hyperexcretion. Hypersecretion of, yes, parathyroid hormone. If there is a condition where it's produced in excess, then it does its job in excess, and it does cause osteoporosis. Yes, it does. The second type of example is something called a neural stimulus, where there's a nerve stimulus coming down. And the best example of a nerve stimulus is in the medulla of the suprarenal gland or adrenal gland. It's Actually, better to call it suprarenal, not adrenal, because in us, the gland sits on top of the kidneys. So above the kidneys meaning suprarenal. So from the central nervous system, impulses travel. So let's say this is the medulla of the adrenal gland is connected with the sympathetic nervous system. And if you remember ANP1, sympathetic nervous system was brought into action whenever there was that flight-fright kind of situation, right? So let's say there is a situation where the body has to go into an alert mode. So the sympathetic system is stimulated. It begins, if you remember, from the lateral horn of the spinal cord. Sympathetic fibers come, and these go and synapse on cells in the adrenal medulla. These cells then secrete their hormones, which are epinephrine and norepinephrine. Collectively, they are known as catecholamines. And then they go into the bloodstream, go to the various target organs and cause your pupils to dilate, your bronchi to dilate, your heart rate to go up, and so on. So you can see it's a nerve stimulus which is causing release of a hormone. Here, epinephrine and norepinephrine act like hormones, not like neurotransmitters. So this is known as a neural stimulus. Third is a hormonal stimulus. As I said, one hormone being produced causing release of another hormone. So one good example is from the hypothalamus, you have factors which are known as releasing hormones. These act on the pituitary gland and cause various hormones to be secreted. And then the pituitary hormones act on different glands, causing different hormones to be secreted. So if you look at this picture, so let's say we have something called thyroid releasing hormone being secreted by the hypothalamus. It goes and acts on the anterior part of the pituitary gland and causes thyroid stimulating hormone, this hormone that I mentioned a while ago, to be produced. Thyroid stimulating hormone acts here on the thyroid gland and causes thyroid hormones to be produced. So you can see it's a two-step process. Another example is from the hypothalamus, you might have growth hormone releasing hormone, acts on the pituitary and causes growth hormone to be produced. Just one step. So only two hormones are involved. Okay. So this is kind of, you can see a hormonal basis of secretion. One hormone causing release of another hormone. And we'll do these various hormones which, when we see them. So to see whether you've understood this, first let's take a look at
the four parathyroid glands, shown here as black dots adjacent to the thyroid, secrete parathormone, or PTH, which is involved in regulating blood calcium levels and, indirectly, in controlling blood phosphate levels. Low blood calcium stimulates output of PTH, which mobilizes calcium from bones and aids in its absorption from the intestines and the kidneys to increase the circulating level. When PTH secretion is inhibited, calcium is deposited in the bones, and less calcium is reabsorbed from the intestine and the kidneys until the blood level returns to normal.
And let's take a look at neural mechanism.
During periods of stress, such as preparing to run in a race, the brain signals the adrenal glands to produce epinephrine or adrenaline. Epinephrine increases the rate in which the heart beats. In turn, the increased cardiac output supplies more oxygen to the muscles, putting the body in a heightened state to react. As a longer-term response to stress, cortisol is secreted by the adrenal glands, promoting the release of energy.
And hormonal.
The production of T3 and T4 in a normal functioning gland is controlled by a hormone produced by the hypothalamus, thyrotropin-releasing hormone, or TRH. When released into the hypothalamic hypophyseal portal system, TRH is carried to the anterior pituitary gland, where it attaches to receptors on a specific subset of cells called thyrotropes, and stimulates the thyrotropes to produce thyroid-stimulating hormone, or TSH. The TSH is released into the blood, and as it passes through the thyroid gland, it attaches to receptors on the thyroid follicular epithelial cells, where it stimulates all functions of these cells.
So now, answer a few questions. Suppose there was increase in blood sugar levels and that resulted in secretion of insulin. What would this be an example of? Humoral release of a hormone, or hormonal release of a hormone, or neural release of a hormone? Humoral release. Look at this. I said blood sugar levels. Something in the blood is causing release of this hormone. Insulin is a hormone. So something in the blood causing release of insulin. So this would be humoral release, okay? Not hormonal release. In a hormonal release, you have to have a chain reaction. One hormone causing release of another, causing release of another. Take a look at this question. Thyroid stimulating hormone acts on the thyroid gland and causes secretion of thyroid hormones. What would this be an example of? Hormonal release, yes. So you can see one hormone causing the release of another one. So hormone and hormone, so it becomes hormonal control. Now read this one carefully. So first I'm telling you that during bright light, the sympathetic nervous system is stimulated through retinal impulses. This in turn depresses melatonin secretion through the action of norepinephrine released by the sympathetic nervous system. So what would this be an example of? So you need to kind of break this down in your head before you think about this answer. This is hormonal and neural. And here's why. So we have light stimulating the sympathetic nervous system. And then I said the sympathetic nervous system depresses melatonin secretion, but that is done through the action of norepinephrine released by the sympathetic. So sympathetic nervous system goes and on the adrenal medulla causes release of norepinephrine. So it's nervous system causing release of norepinephrine. So this is the nervous control. Norepinephrine prevents or depresses melatonin secretion. So it's acting on another hormone, which is melatonin. So here is one hormone acting on another. So this is hormonal control. So you can see this involves both neural as well as hormonal. Okay. So it's you have to be very careful when you're reading these questions, because you might have questions which kind of have two things thrown into it. If you see the word blood mentioned, it's always going to be humoral. If you see one hormone and then another hormone down the chain, it's always going to be hormonal. But if you see something like this, where two get together, it would be a combination of both, okay? So now let's start looking at the various organs which are part of the endocrine system, okay? So we'll begin with the top, the hypothalamus. So when you look at the hypothalamus actually has two parts to it. There's a part which is called the posterior hypothalamus, and there's a part which is called the anterior hypothalamus. The hypothalamus, the entire hypothalamus is connected, as you can see here, to the pituitary gland, which lies below it, by a stalk, which is known as the infundibulum, a connecting stalk. The posterior hypothalamus is connected to the posterior pituitary, because even the pituitary gland is actually divided into two parts. A posterior pituitary, or also known as the posterior lobe, and an anterior pituitary, also known as an anterior lobe. So this is the posterior and this is the anterior. So posterior hypothalamus connected to the posterior pituitary, anterior hypothalamus connected to the anterior pituitary. And remember, I told you that the hypothalamus was what was called the master gland, because it kind of tells the pituitary what to do, okay? So let's begin with the posterior hypothalamus. So in the posterior hypothalamus, you have various nuclei present, of which 2 nuclei are extremely important. You don't need to remember the name. So these are the nuclei, and if you remember from ANP1, the word nucleus means that that is where nerve cell bodies or neuronal cell bodies are collected. Nucleus means where cell bodies of neurons are present. And a neuron has a cell body, it has axons and dendrites, right? So these neurons, the cell bodies are present here. They produce hormones which travel down the axons, and then they will come and we'll see what happens when they come to the pituitary gland. So here are these 2 nuclei. One is called paraventricular, one is called supraoptic nucleus. These 2 nuclei, the neurons over there in the posterior hypothalamus, they produce 2 hormones, which are called oxytocin and antidiuretic hormones. So these 2 hormones are produced in the posterior hypothalamus, oxytocin and ADH, which is antidiuretic hormone. Now take a look at this picture very, very clearly. These neurons, which are originating in these 2 nuclei, their axons travel all the way down from the hypothalamus into this connecting stalk called the infundibulum, and they come and end in the posterior pituitary. So these axons are extremely long, okay? They come and end in the posterior pituitary. From ANP1 again, if you remember when you did the nervous system, just as nucleus means collection of nerve cell bodies, when you have a collection of axons are known as tracts. Okay, another thing you may, nerve. When you use the word nerve, what does a nerve really have? Nerve fibers. Nerve fibers are nothing else but axons. We also use the word tract for a collection of axons. So this tract, which you can see coming from the hypothalamus to the pituitary, which is axons from these 2 nuclei, this tract is known as the hypothalamic or hypothalamo-hypophyseal tract. Hypothalamo is because from the hypothalamus. Hypophyseal is because the pituitary gland is also known as the hypophysis. Hypophysis cerebri. If you remember skeletal system, in the skull, on the base of the skull, in the sphenoid bone, there was a little fossa called the hypophyseal fossa. Does that ring a bell? That hypophyseal fossa had the pituitary gland, and you can see why it was called hypophyseal, because the pituitary is also known as hypophysis, okay? So here is this nerve tract which you can see coming all the way down from the posterior hypothalamus to the posterior pituitary. In the posterior pituitary, you can see that there are various blood vessels. But what happens is that at the endings of these axons, there are swellings which are called axon terminals. This oxytocin and ADH, which is produced here, comes down and gets stored here in the posterior pituitary. Then when the body needs oxytocin and ADH, the posterior pituitary releases it. It releases it into this bloodstream, because that's what hormones do, right? They get released into the bloodstream. And then oxytocin and ADH will go and act on their target tissues. ADH acts on the kidney tubules, oxytocin acts on the uterus and the mammary gland. Followed? Okay? Anterior hypothalamus. So let's look at the anterior hypothalamus. I will come to the actions of ADH and oxytocin later. The anterior hypothalamus, it produces a bunch of hormones, and these hormones are either releasing hormones or inhibiting hormones. The releasing hormones will have a RH in front of them. The inhibiting hormones will have an IH in front of them. RH, and this one will have IH. So let's take a look at these releasing hormones. Growth hormone releasing hormone. Thyroid releasing hormone. Okay, TRH, thyroid releasing hormone. CRH is corticotropin releasing hormone. This is called gonadotropic releasing hormone. Sometimes people say there's something called prolactin releasing hormone. That's a bit iffy. Some don't agree with it, so we won't include it here. So you can see these are the releasing hormones. Look at the inhibiting hormones: growth hormone, inhibiting hormone, and prolactin inhibiting hormone. So here what these neurons do, if growth hormone needs to be released, the releasing hormone will be secreted, and then it will go and have growth hormone secreted from the pituitary. If inhibiting hormone needs to be released, or rather the secretion of growth hormone needs to be inhibited, then the inhibiting hormone will be released. It will go and inhibit the secretion of growth hormone, and that will no longer be secreted. So the name is kind of explanatory, okay? So let's see how this anterior hypothalamus is connected to the anterior pituitary. So these neurons up here, so hypothalamus is part of the brain, the neurons there secrete these hormones, releasing and inhibiting. They go, their axons are short, they come and they sort of release their hormones into blood vessels, a capillary system which you can see in the infundibulum. And this capillary system is an extremely long capillary system. So there's one bunch of capillaries, and then veins start there, and another bunch of capillaries up in the pituitary. So this whole capillary system is known as the hypothalamo-hypophyseal portal system, or just hypophyseal portal system. The reason it is called portal system, if you remember when we did the circulatory system, you remember there was that portal vein which was formed, right? The vein was formed by the splenic artery and the splenic and the superior mesenteric vein. Sorry, not artery, splenic and superior mesenteric vein. And you form the portal vein. So these began from capillaries, and then they formed a vein, and the vein goes into the liver and breaks up again into a second set of capillaries. So can you see that there are two sets of capillaries? So in the circulatory system, whenever there are two sets of capillaries, we call it a portal system. So same here. Here's the first set of capillaries, and then it comes down and breaks up into another set of capillaries. So that's why it's called a portal system, okay? So they secrete their hormones which go into the bloodstream, which goes into the anterior pituitary, and then they either stimulate or inhibit the secretion of hormones from the anterior pituitary. These are the hormones which are secreted from the anterior pituitary. Growth hormone, so that is controlled by either the growth hormone releasing or the inhibiting. Thyroid stimulating hormone, which is controlled by the thyroid releasing hormone. ACTH stands for adrenocorticotropic hormone. That is controlled by the corticotropic releasing hormone. FSH and LH are hormones which act on the gonads or the reproductive, and these are also known as gonadotropins. So they will be controlled by the gonadotropic releasing hormone. And then prolactin is controlled by the prolactin inhibiting hormone. Okay, so the anterior pituitary, as you can see, produces its own set of hormones, but it is controlled from the hypothalamus. Posterior pituitary, on the other hand, does not produce any hormones. It only stores those hormones which are coming down that tract. Have you followed that? Okay.
Could you say it one more time?
Yes. The anterior pituitary produces its own set of hormones, which you can see up here, right? But these are controlled by a set of hormones which comes from the anterior hypothalamus. The posterior pituitary, as we saw in the previous slide, the posterior pituitary is not producing its own hormones. It's only storing what the posterior hypothalamus sent to it, and then when needed, it secretes that. Okay, so there are no cells in the posterior pituitary which secrete those hormones, which actually produce those hormones. Okay, got that? So let's take a look at these two questions. How do the hormones produced by the posterior hypothalamus reach the posterior pituitary? through a nerve tract. Yes, not through a capillary plexus. This is through a nerve tract, and that's why I kind of showed you the picture. Look at this. Look at this nerve tract. This tract is coming all the way down here. So through a nerve tract. How about this one? How is the anterior hypothalamus connected to the anterior pituitary? Very good. By means of blood vessels, that hypophyseal portal system or hypothalamo-hypophyseal portal system. Now let's look at what are the actions of these hormones. So first let's look at what is produced by the posterior hypothalamus and stored in the posterior pituitary, and it's called the posterior lobe of the posterior pituitary. This posterior lobe, just in case you read it somewhere, is also known as neurohypophysis. So neurohypophysis. And again, this should tell you, this will help you to remember, because because it's connected by that neural tract, okay? It stores two hormones produced in the hypothalamus, posterior hypothalamus. The two hormones were ADH, anti-diuretic hormone, which is also called vasopressin. Wherever hormones have different names, it's a good idea to remember them, because you can remember actions accordingly. The word anti-diuretic. Anti-diuretic. Diuresis means to produce urine, pass urine. Anti means it prevents too much urine being passed out, right? So in other words, if you don't pass too much urine, what will happen? That water will be conserved by your body. So you can see the function of this hormone is to conserve water, anti-diuretic. If you're not passing urine, that urine is going to be conserved by your body, right? How does it do that? It causes reabsorption of water from the kidney, and this reabsorption acts in the kidney tubule. So when we do the urinary system, we'll be talking about this hormone again, because it's the kidney which finally causes, is responsible for the formation of urine. So here, where the kidney, on the kidney tubules, the action of ADH is where it occurs. So what it does is that if the body needs to conserve water, it will make the kidney tubules permeable to water, so water will enter inside the kidney tubules. From there, it will go into the bloodstream, and you'll pass less urine. So that's how it gets its name, anti-diuretic. Another name of it is vasopressin. So if you think of this name, vaso, the word vaso means blood vessel. The word pressor means to constrict or increase tension. So you can see it therefore causes it has a vasoconstrictive action on the blood vessels. If you tie this in with the circulatory system, think of this situation. If somebody has lost a lot of blood, or they have been having severe diarrhea or severe vomiting, what is happening at that time? They have lost a lot of fluid, so their blood volume will come down, isn't it? Because after all, that fluid is pulled out from the blood. When their blood volume comes down, what happens to blood pressure? Blood pressure also falls. So it's good to have a hormone which will, and remember, how do you keep your blood pressure up? By constricting blood vessels, which increases peripheral resistance, and that's how your blood pressure goes up. So can you see how this helps? If you have lost a lot of fluid, you do not want to be passing more urine at that time, because you lose even more water. So ADH would be secreted at that point, so that it removes water from the kidney tubules and pushes it back into the bloodstream. So therefore, it will help to increase your blood volume. So it takes care of one problem. Second, your blood pressure is dropping. This has a direct action on the blood vessels. It constricts it, raises the peripheral resistance, hence helps to raise the blood pressure. Okay? So you can see how important this is. What are some of the things which will cause release of ADH? Exactly like I told you. If there is increased solutes in your blood, which is known as when there is increased osmotic pressure in your blood. And again, if you think back on circulatory system. What is osmotic pressure dependent on? The amount of solutes present, right? So when you lose a lot of fluid, the solutes remain in your blood, so it makes the blood hyperosmotic. That hyperosmotic blood travels all the way, it goes to the hypothalamus, where you have something known as osmoreceptors. Those osmoreceptors sense this increased osmotic pressure in the blood. They secrete ADH and it does its job. Low blood volume, low blood pressure, both of these will indirectly raise the osmotic pressure, right? Low blood volume will be when you vomit, when you have diarrhea, or you're hemorrhaging. That leads to low blood pressure, which automatically, when you lose fluid, your osmotic pressure rises. Pain also, when severe pain also tends to really cause release of ADH. So whenever you're thinking of any hormone, there are two things you must think of. One is, what is the stimulus for release of the hormone, stimulus for that hormone release, and then what is the action of that hormone. So you can understand that whatever the action of the hormone is, automatically you should be able to work out the stimulus. If the action of the hormone is to raise blood pressure or increase blood volume, so the stimulus will be exactly opposite. That means whenever the blood pressure has fallen or whenever the blood volume has fallen, because only then that hormone will be secreted so that it's able to do its job. Okay? Yes. Well, pain acts in a lot of different ways. It doesn't have this blood volume, blood pressure effect at that time. Pain actually even causes sympathetic system release, and sympathetic has some sort of an indirect action on ADH release. So that's how it does that. It's nothing to do with blood volume and blood pressure falling. Yeah. So pain acts through a different cycle. So there's a different kind of loop through which pain acts. Pardon? Pain through the nervous system uses neurotransmitters, but in the end it is a hormone which is being released. And when you have severe pain, it's like at that time your body has to be on this alert system, right? And so you do not want to be passing urine and doing all that, right? So you want to conserve water. You don't want to take care of these ordinary day-to-day activities. You see what I mean? So that's the loop that comes around. So you've got to think that way. Okay? See, when you have pain, your body, like the sympathetic system gets activated, the parasympathetic gets depressed. And the sympathetic has some sort of an action on ADH also, so it probably causes ADH release. Okay? Let's look at oxytocin. Oxytocin acts on the uterus and it acts on the mammary gland. It causes contraction of uterine musculature, so a lot of the uterus has a lot of receptors, oxytocin receptors, which respond during labor. And in the breast tissue, what it does is it doesn't increase the production of milk, but helps to eject milk. So that is known, where in the glands of the breast, there are cells which, and I think I might have mentioned this before, that how the autonomic nervous system acts on glands. Because when you think of glandular secretion, a gland is just made up of cells. So let's take a gland like this. It's made up of these cells. But around the cells, you actually have smooth muscle cells, which are known as myoepithelial cells. So the parasympathetic or sympathetic, or in this case, the endocrine system, they act on these myoepithelial cells. When these contract, what they do is they squeeze the gland, and then the gland can pour out its secretion. So this oxytocin helps this myoepithelial cells in the breast mammary gland to squeeze the gland and eject milk. So it's not for doesn't increase production, but it increases ejection of milk. It also, so these two would be during labor and post-labor, okay? But actually, if you did a search on oxytocin, now, previously they thought oxytocin, that's all that it did. It acted during labor and post-labor, during lactation. Now, if you did a search on oxytocin, it's actually called the love hormone, or also known as the cuddle hormone. You had a question?
I just wondered if you were one to point out how the hormone that causes the woman's most pain is also the one that gives her the most affectionate feeling.
Yes, exactly, right. I mean, during labor you have a lot of pain. Yes, it does that, but it helps you kind of proceed with it. But yes, it is very good. That's why it's called the love hormone, because it generates feelings of affection. And different kinds of affection, the ones that you have for a child, the ones that you have for a partner, the ones that you have for your parents, the different kinds of feelings are generated by oxytocin. And now, actually, people kind of downplay this, and they say that this is more important, this feeling of affection and so on. And it's how this oxytocin levels remain in your blood. And, there are various books, and I don't want to go too much into detail about this, but in men, apparently it's produced and then removed as fast, whereas women, it's produced and tends to remain for a bit longer, So, if I remember the name of the book, I'll tell you that book, Why Women Never Forget and Why Men Don't Remember and Women Never Forget. That's a really nice book. Try and read that book, and you will enjoy it if you get it. Try and read it during the break, because it has a lot to do with endocrine system, and you'll understand it, because it talks on how this oxytocin is liberated, and how in women, because it stays longer and you tend to kind of think more in the future. Men, it gets produced and then gets removed equally fast. Okay, it's a really nice book to read, and it's more from a science point of view than just fiction. Yes.
Okay, why do women have to take stimulus pills to create breast milk? Like, when they can't make it, what is the reason for that? Are they not getting enough oxytocin?
No, oxytocin is only for ejection of milk. When they are not making enough, they are taking another hormone, which we'll talk about, which is prolactin. Prolactin is the one which increases production of breast milk. Lactin, see the word lactin for lactation. Pro, making it secrete. So oxytocin at that time is only for ejection. Prolactin is the one to produce more breast milk. Okay, so not this. This oxytocin, you will see that most hormones are under a negative feedback control. Even ADH is under a negative feedback. Once it does its job, it kind of gets turned off. Oxytocin is one of those hormones which is under what is called a positive feedback mechanism. So here's what happens. Let's take one example of labor. So the fetal head pushes against the cervix dilates. This dilation of the cervix actually sends impulses to the brain, and it goes to the posterior pituitary where oxytocin is stored. Oxytocin is released. It goes and acts on the uterus, which makes the uterus contract, pushes the head down further, the cervix dilates even more, impulses keep going on, so it kind of goes on and on, the loop keeps going on. So this is a positive feedback. The same happens with during breastfeeding. They say the more you nurse your child, the more milk you produce, because when you nurse your child, that oxytocin helps to release that stimulates the production of more milk, where prolactin is also acting. And the more milk there is, the more the child will feed, which means more oxytocin is released, and it goes on. So this is a positive feedback mechanism. One of the few instances in the endocrine system where you have this kind of positive mechanism. Most of the time you'll see in the endocrine system there's a negative feedback. The reason there is positive is because this labor, for example, does not go on endlessly. Once labor is done, there's no need for the uterus to contract. Of course it does for some time, but beyond that. Same way, once you stop lactation, it doesn't go on and on. Whereas all of those other hormones act throughout your life, all the time. This oxytocin acting on the uterus or the mammary gland is only for the period of labor or lactation. Okay, so that's why it's under positive feedback control. So let's review this. So you'll have a lot of these review slides, and take a look at them. They're really explanatory. So if there is high blood osmotic pressure, like for example, as I said, you have diarrhea, vomiting, all of that, it stimulates those osmoreceptors in the hypothalamus. They synthesize ADH, they pass it to the posterior pituitary gland, the posterior pituitary releases it, and so ADH acts on the kidneys, and it causes the kidneys to retain water, so your urine output is decreased. At the same time, also, you want to make sure that you do not lose water anyway. So it also inhibits the sweat glands, because if you were sweating too much at that time, then that would also, cause water loss. So your sweat glands, secretion from the sweat glands decreases, so there's less water loss from perspiration, and oxytocin, which is vasopressin, controls your blood pressure by vasoconstricting. Yep.
Does that also happen when you have a fever? Does your body like contain water?
No, fever does not act on ADH. No. Yeah, I mean, at fever, in fact, when you have a fever, because your temperature has gone up, you sweat more. Because the hypothalamus also has a function of being a thermostat. So when you have very high fever, you'll notice you sweat more because your hypothalamus tries to bring your body temperature down. At that time, there's no relationship to ADH. Okay? So let's now just review some of these. We should get 100% on this one. Vasoconstriction, yes. Okay, so now I'm giving you situations. When do you think ADH would not be secreted? I was kind of trying to think how people sat, put their names in. Very good. Most of you got this right. So, poor Kenny, having diarrhea, a lot of water going out of his body, blood volume, blood pressure falls. So, you do not want to lose water. So, ADH would be secreted. Nicole, who's, again, same thing, she's just doing it at the other end. So, again, losing water, want to conserve water, so ADH, you want ADH to be secreted. Lauren, again, sweating, losing too much water, especially people who work on a very hot day outside in the sun, they sweat a lot and they don't drink enough water and solutes with it, will produce ADH. She's drinking, she's already overloading her body with extra water. So whenever you notice that, whenever you drink a lot, you tend to kind of pass more urine at that time, okay? Alcohol, one interesting fact about alcohol is not only is it fluid that you drink, but it's also, alcohol directly also inhibits ADH release. So you do not have to drink tall glasses of alcohol, like beer or whatever, many glasses of wine. Even if you take a few shots, you will find that you will tend to pass more urine because alcohol by itself has a depressant action on ADH release. So if ADH is not released, what happens? You'll end up passing more urine. Which is why they say when you go on an aircraft, because you're stuck for a very long time, if you drink too much alcohol, you'll end up getting dehydrated, right? Because just that alcohol kind of helps that. And you will see that if next time you'll go to the bar, see what happens when you have a few shots, try a few shots and then just try it. Yeah, so Fatyan agrees with me. Yes.
So, another one of the weird statements. But so when, you've had beers or whatever, and they say, okay, well, I don't want to go to the bathroom because I'm breaking the seal, essentially. And once you go bathroom the first time, it seems like you have to keep going. But it's not necessarily, okay, now you started it and it's going. It's that it's your hormones are
It's exactly, it's that. And it takes about half an hour for once you start drinking for you to be passing. Yeah. And it's the volume. If you drink a lot of beer, imagine you're overloading your system, so the homeostasis has to be done. Your body wants to bring about homeostasis, so wanting to get rid of that extra. Plus, at the same time, there's that alcohol, which is depressing ADH also. So it's like a double action there.
So essentially, if you want to get problems, here's the way to do it. You should still get a hard stuff, so that way you're not.
No, you'll still get dehydrated. You'll still get, yeah, you'll still get dehydrated. Probably. Well, I don't know whether you would get more, because when you take in fluid, when you're taking the fluid in, it's going to get rid of that excess fluid. Okay, so it's that. So if you have one full glass of whole beer, it's that excess fluid plus that alcohol. Now, if you just have a shot, well, you may be passing less. You'll still go frequently, but with each output may not be as much as, because you don't have that much volume to get rid of. You see what I mean? Okay. So either way, I guess too much is too bad. Yeah. Yeah. Now here, let's look at a situation. Who is likely to produce more ADH? Good job. Yes, Stella, who unfortunately is severely dehydrated. Then you want to conserve water, you want to produce ADH. Sabrina's been drinking lemonade all day, already a lot of fluid. She wants to get rid of that fluid, so no ADH. Celine, given more IV fluids, but someone didn't pay attention, so you got to get rid of the excess IV fluids, right? And Olivia, hers is a normal situation, right? Just a minor cut on her thumb and on wherever, and she had to have it sutured. So she's really not lost too much blood or anything, okay? So here, she's the one who's going to be the one who's going to produce more ADH, okay? So I'm glad you're carrying on, you're getting the concept, because your questions are going to be like this, where I really I do want you to know the actions, but I want you to be able to apply those actions. Yeah. Yeah, I change it every year, so yeah, so I've got to kind of put more questions with everybody else's names. So let's look at the anterior pituitary now. So we looked at posterior hypothalamus, posterior pituitary. Now look at the anterior pituitary. Remember, most of these are controlled by those releasing hormones which came from the hypothalamus. Few like prolactin and growth hormone have inhibiting hormones as well. And these are the hormones which are produced by the anterior pituitary. ACTH, adrenocorticotropic hormone. As the name suggests, adrenocortico. So it acts on adrenal cortex. And then we'll see that it will cause release of hormones from the adrenal cortex. Thyroid stimulating hormone stimulates the thyroid. This is called follicle stimulating hormone. It acts on the gonads. These two act on the gonads. So collectively, they're also known as gonadotropins. Gonadotropins. Okay? See this use of the word tropin. Corticotropic. This TSH is also called thyrotropic. We call it thyroid stimulating, but thyrotropic. LH stands for luteinizing hormone, growth hormone, prolactin, and this one is called melanocyte stimulating hormone, which is basically acts more like a neurotransmitter, really. So wherever you have the word tropic or tropin with it, it means that it regulates the secretory activity of another gland. So for example, adrenocorticotropic hormone will act on the adrenal cortex and cause secretion of hormones from the cortex. So it's acting on another gland, so this is tropic. Thyroid stimulating stimulates the thyroid, causes secretion from the thyroid. So that's what tropic hormones are, which cause secretory activity from another gland. Okay? So even the releasing hormones are tropic hormones because they cause release from here, from the anterior pituitary. So here let's look at the growth hormone, because all of these other hormones, TSH, FSH, LH, FSH and LH we'll do when we do the gonads. TSH acts on the thyroid, so with the thyroid we'll see. So all it does is kind of acts on the thyroid. I'll talk a little bit about prolactin. MSH is a neurotransmitter. So let's look at the important one, growth hormone. Very important hormone. If there is low blood glucose levels, because growth hormone increases blood glucose levels, but if there's low blood glucose or growth hormone releasing hormone, and exercise. These are some of the triggers for growth hormone release. Naturally, it's inhibited by the inhibiting hormone. It acts on the musculoskeletal system. It increases the activity of the epiphyseal plate. It increases muscular growth, causes protein synthesis. So therefore, it is known as an anabolic hormone, where it kind of builds up tissue. Okay? So on the musculoskeletal system, on the skeletal system, increases this interstitial growth, right? So that's why people, growth hormone, during the growing periods, they grow in height. After the epiphyseal plates have fused, growth hormone can still act. So if there was excess, what it will do is it will cause bone to be deposited on the skeleton on the outside, on the circumference, which is called appositional growth. So bones actually become thicker because you can't increase in height. Same way, acts on the muscular system as well, increases muscle. And, sometimes people take growth hormone, synthetic preparations to increase their bulk. Another function of the growth hormone is it's called the diabetogenic effect, because what it does is it breaks down fat and makes fat into glucose, and that raises the blood glucose levels. So it doesn't use up glucose. Instead, it causes more glucose to be produced so that blood glucose levels rise. So that's why it's known as the diabetogenic effect, because in diabetes mellitus, the blood glucose levels are high. Okay? In normal people, this does not, it's okay, because that excess glucose goes back into the cells because we produce normal amounts of insulin. Protein synthesis is produced and, important for cell and tissue growth. One interesting fact about this hormone is more is produced during sleep, especially in childhood, which is why little children are, are told, and we like them to sleep for longer periods. During teens, we ask them to sleep, get their full sleep, because that's when maximum growth occurs, and that's when more of the growth hormone is produced. Yeah, you have a question? Steroids are different. Steroids also act on the musculoskeletal. They are also anabolic. That's why they're called anabolic steroids. But if you take any of these in excess, it will do the job that you're taking them for. But because there's excess of the hormone, it will also have the harmful effects of that. So when you take anabolic steroids, for example, rage, people have that steroid rage. They might end up with acne and, all of the other products, because steroids tend to increase the activity of, make the skin a bit oily. And okay. Other anterior pituitary hormones, prolactin, it's important. Prolactin is important for milk production, so increases production of milk, obviously during the lactation period. Melanocyte stimulating hormone is a neurotransmitter. And we have other hormones produced in the pituitary called endorphins and enkephalins. These are becoming very, very important now, because endorphins are those which kind of help you to help to make you feel good. So, when you exercise, for example, endorphins are released and you have that feeling of well-being and feeling of just feeling good. Endorphins also help to reduce pain. So alternative therapy, something like acupuncture, what it really does is that, at those trigger points when they put their needles, they think that causes release of endorphins, which dampen the pain that you're feeling, and that's the way the acupuncture actually acts, So endorphins and enkephalins are produced in lots of areas of the nervous system, not only in the anterior pituitary, and they have lots of functions. One of the functions that you should know of, this making you feel good, so, or feeling of well-being. Yeah. Normally by yourself, exercising. Exercise is a good thing. You might notice that if you have pain anywhere, but you still can go and take a walk or something, you tend to feel a bit better after that. Maybe a meditation, yoga, all of this kind of helps to release endorphins. And so in a natural way, that's how you can do that. Okay? Yeah. So let's look at the growth hormone. So up here, releasing hormone acts on the anterior pituitary, which produces growth hormone. Let's look at its direct action. It's metabolic. It's anti-insulin because it raises the blood glucose levels. So, you can, I'm not going to repeat this. So take a look. Increased protein synthesis, cell growth, breaks down fat, lipolysis occurs, increases blood glucose. So that's how it's against insulin in the skeletal system. It acts on the epiphyseal cartilage and helps with skeletal growth. Again, causes protein synthesis, and it's growth hormone inhibiting hormone. When you have enough growth hormone, if the level goes up, inhibiting hormone will be secreted, and that will reduce the amount of growth hormone being produced. So, pay attention to this whole chart. All of this is what we just went over. So let's look at some clinical conditions of hypersecretion of growth hormone. When growth hormone is secreted before the epiphyseal plates have fused, so before epiphyseal plates have fused, usually epiphyseal plates fuse by about, or growth plates, they fuse by about 18 years in women and about 21, 22 in males. And, they stop growing after that. If there is excess growth hormone, what happens is that it keeps stimulating the epiphyseal plates. A person grows really, really tall, and that condition is known as gigantism, where here you can see this boy, young boy, probably 14 or 15, and look how tall this person is, okay? So this is before the growth plates have fused, before fusion of growth plates. After the growth plates have fused, this is after fusion, it still acts on the skeletal system, still acts on muscular system, still acts on, increasing protein synthesis and all. But now you can't increase in height because the epiphyseal plates have already fused. So here what it does is it increases the thickness of bone, which becomes very, very easily seen. And this leads to a condition which is known as acromegaly. So this is a picture of a person, young person. This is how she was. She had a pituitary tumor which increased the production of growth hormone. So she may have been about 25 or something. So her plates had fused. And slowly look at how she became. So one of the features you see in acromegaly, the bones become very, very thick. So this thickness is easily seen in the jaw. So the jaw becomes extremely thick and kind of sticks out. The fingers become very thick because the phalanges and the metacarpals, again, even the toes, they'll become very thick. So the hands look very thick. So you can see up here, skin looks extremely thick. It doesn't have that fine quality to it. So this is what has changed in this person, acromegaly. So this is hypersecretion of growth hormone, and this gigantism is hypersecretion, but before the growth plates have fused.
Is there a way to control this?
Yes, usually it's due to a pituitary tumor, and I'll show you how they do that.
Red's Red Carpet Tips.
There's no such thing as too much collagen.
Oh, Red, I couldn't feel my face.
The world's tallest woman has undergone surgery to prevent her being paralysed and going blind. Sadiqa Parveen, who is estimated to be 7 foot 8 inches tall, was taken to New Delhi's All India Institute of Medical Sciences for the removal of a tumour on her pituitary gland, which was causing her rapid growth.
There's a limit to what body can do. She would have decompensated, there would have been more fractures. And usually these patients can die of cardiomyopathy, heart failure. The only surgery we could remove the tumor, we used the most high-tech endoscopes.
26-year-old Sadiqa, from a remote village in West Bengal, has suffered from the form of giantism from the age of 15. In 2013, she was recognised by Guinness as the world's tallest living woman, but the condition has had serious effects on her health, as she began to lose sight and was suffering from fractures in her spine. After being admitted to hospital in January of this year, Sadiqa's size presented many challenges for the doctors.
The aortic surgery requires bigger endotracheal tubes. Even the BP cuff, the blood pressure cuff, which is used for the thigh, we use for a normal thigh, we use on her arm because her arm was so huge. Then post-operatively was another challenge to manage her in the intensive care on a 6 feet bed, which had to be reinforced.
Following the surgery, Sadiqa will remain under the watchful eye of the doctors.
She has a big body, but a very weak body. So she requires a lot of rehabilitation.
But they hope over time fractures to her spine caused by the crushing weight will heal and improve her quality of life.
So, had it been discovered earlier in her case, so much could have been prevented. You know, she was 26 when she went up for surgery. So, had she gone a bit earlier, you can halt it. So, it's early discovery, you can remove the tumor. What's that? But she's so tall, the weight can't take, you know, she can't take, so she says the weight is so much that she's kind of stooped over. There's some people who can remain tall, and every case is not the same. In her case, you know, the weight and the bone may have been extremely dense as well, so then, you know, it said that the weight was crushing her vertebrae, which is why she got bent over. Not everybody necessarily is, but if you go with the problem, the longer you go, the more the problems are going to be, you know. Yes.
And once she has the surgery, does it get reversed?
No. That height, no, she's never going to go back. The epiphyses have grown, so the bones are not going to shrink. She's not going to have further problems. What's that? Well, to stand up straight, because the vertebrae, from that video where they said the vertebrae were crushed, they probably would have to do spine surgery to make her erect. You know, it's not that just because you took it off that from a bent position, she's going to go back straight. You know? Yes.
Density change after they take that out? Because
well, if all her other hormones are normal, you know, yeah, she's not going to become osteoporotic. I doubt whether the
same back to a normal level, but even
could well, it depends on her blood calcium levels at that time, because we'll see that there are two hormones will act on the calcium. So if her calcium levels are okay, her density also may remain the same. So here we did that was hypersecretion. This is a condition known as hyposecretion of, and there are two hyposecretory conditions. One is hyposecretion of growth hormone, and that is called pituitary dwarfism. So you can see these are 15 years old, all of these, and this little girl is with her classmates, and you can see how tiny she is, you know. So then there was hyposecretion, so her musculoskeletal system did not develop as properly. She's proportionate. See, that's pituitary dwarfism is different from something known as achondroplasia, where they are not proportionate. She's proportionate, just extremely tiny. Okay? And then there's a condition where this is not growth hormone, where there is hyposecretion of ADH. And this condition is called diabetes insipidus. There are two. When you say diabetes, you know, oh, this person has diabetes, type 2 diabetes, what you're talking about is diabetes mellitus, which we will see later. And it's called mellitus because urine is sweet. Diabetes, sweet urine. Diabetes insipidus is where you produce a lot of urine, but the urine is not sweet. So that's how you can differentiate it from diabetes mellitus. In both types of diabetes, you produce a lot of urine. And when we do the pancreas, I'll tell you why you produce a lot of urine in the other diabetes. In this one, because there is less ADH, automatically, obviously, what will happen? The person will keep on producing urine, right? The body cannot conserve water. But the urine does not have sugar in it, so that's why it's called diabetes insipidus. So let's look at, see if you can figure this out. Why children, you know, most children, I mean, I know obesity is becoming a big problem nowadays, but as a general rule, if children exercise and do all of the things, don't eat too much, why do you think they are normally lean during the growing period? Yes, very good. Growth hormone causes fat breakdown. So that's an advantage which we have during the growing period, right? So that's why they have that. Not because their bones are ossifying. The bones are ossifying, that's calcium and collagen. Nothing to do with being lean is whether you have too much fat or too little fat. So the fat is broken down, so they, and which gives the, gives them the energy. Yes, but there, remember over there, exercise was one of the triggers for growth hormone release. Yes, yes, yep. So, what complication do you think a person with diabetes insipidus is likely to have? Dehydration. See, not high blood sugar. Remember, growth hormone, if you have diabetes insipidus is because of low ADH. ADH only acts on conservation of water, or vasopressin acts to increase blood pressure. So if you have less of it, you're going to pass more urine, so you automatically get dehydrated. You can't have low blood pressure. Because you're dehydrated, your blood pressure will come down because you're low ADH. It has nothing to do with short stature, because ADH does not control your growth and neither does it control your sugar. So those of you who chose that were probably thinking about growth hormone. But remember, diabetes insipidus is because of low amounts of ADH being produced, okay? Nothing to do with growth hormone. Let's now look at the feedback. So I showed you, I explained what positive feedback was, but negative feedback, which is what happens in most of your endocrine glands, what happens is from the hypothalamus, you have a releasing hormone produced, and I've given you an example of thyroid releasing hormone, which is released from the anterior hypothalamus, goes to the anterior pituitary, where it causes thyroid stimulating hormone to be produced. So this, I could have corticotropic releasing, ACTH, I could use anything. This then goes to the thyroid gland, and thyroid gland produces thyroid hormones called thyroxine and T3, and we'll see that. These, when the levels of thyroxine and T3 in the blood get to optimum levels, that circulates and goes back and inhibits the release of TRH as well as inhibits the release of TSH. So therefore, no more TRH and TSH, which means thyroid gland is no longer stimulated, so the levels will begin to start falling. So they were going up, the levels will start falling. When they reach a point where the levels have fallen below what you want them to, this negative effect will go back off, and the levels will, again, this will be released, and more of this, so it will come like this. So it will keep having this cyclical kind of pattern, okay? And so that makes sure that you never get into a hypo or a hyper secretion normally. So let's look at feedback.
My lower back pain. Horrible. So excruciating. It was
in which the secretion of a hormone causes effects in target cells that inhibit further secretion of that hormone. Negative feedback is an important way of maintaining homeostasis, that is, keeping conditions within the body relatively constant over time. For example, it is important to maintain the level of glucose in your blood at about 100 milligrams per 100 milliliters. After a normal fast food meal with a large Coke, your blood glucose levels undoubtedly shoot up well beyond the normal level. Receptors on specific cells in your pancreas detect the increased blood glucose level, and as a result, these cells secrete the hormone insulin into your bloodstream. The insulin molecules, in turn, bind to target cells throughout the body and cause them to increase their intake of glucose. This results in glucose levels in your blood going back down to normal levels. Detecting this, pancreatic cells that secrete insulin stop the release of insulin into the bloodstream to ensure that glucose doesn't drop below normal. Occasionally, positive feedback controls hormone release. Contractions of the uterus early in childbirth causes the release of oxytocin by the posterior pituitary. The oxytocin stimulates stronger contractions of the uterus in turn causing more oxytocin release, and so on, creating a positive feedback cycle that continues until the infant is finally pushed out into the world.
So, let's look at this. The more a woman nurses her baby, the more prolactin she secretes, the more milk she produces. What is this an example of? Positive. See, I'm saying the more she secretes, the more she produces. So it's a loop that's going on. You see this word more and more. Okay, so this is a positive feedback. Let's look at the thyroid gland now. So it's a bilobed gland. You did the respiratory system last time, so some of these you're familiar with. Here's the thyroid cartilage, and below that is the cricoid cartilage, and then these are the tracheal rings. So this thyroid gland lies in the neck. It's two lobes joined by a bridge which is called the isthmus. These lobes can go up to the thyroid cartilage. So quite often you might see the lobes kind of going up to the thyroid cartilage. Since it's endocrine, it's extremely well supplied with blood vessels. So you can see all these blood vessels going to it. So you can see it's lying in front of the trachea. It lies on the side of the trachea, and a small part of it will be lying on the, sort of just going on the back. And on the posterior aspect of the thyroid gland, we'll see two more glands on each side, which are called parathyroids. They are absolutely separate from the thyroid and do their own thing. This gland produces two types of hormones, and both types have absolutely separate functions. There are cells in the thyroid gland called follicular cells, and there are cells in the gland called parafollicular cells. Para meaning by the side of. So if I took a section of the thyroid gland, I will see these round structures like this. These are what are called the follicular cells of the thyroid gland. And then in between, I might see cells here, which are called parafollicular. Okay? So these ones are parafollicular cells, and these ones are what are called follicular cells. From the follicular cells, you have two hormones produced, which are called thyroxine, or also known as T4, and another hormone called T3, which is called triiodothyronine. I want you to pay attention to the word iodo. So these hormones contain iodine in them. So iodine is very important for production of these hormones. When we use the word thyroid hormones, we are typically talking about thyroxine and T3. We do not talk about calcitonin. Okay? So when we use the word thyroid hormones, we are actually talking only about these. So when we want to say calcitonin, we will use the word separately, calcitonin. So when I ask you a question, thyroid hormones include T3, T4 and calcitonin, that's false, because it doesn't include calcitonin. Okay? So traditionally when we say thyroid hormones, we are really only talking about T4 and T3. They are produced by these follicular cells, as I drew them up here. And so these follicular cells actually secrete the hormones into the lumen of the follicle, and then we'll see by a very complicated process, they kind of come back into the cell and then go into the bloodstream. These parafollicular cells, which produce calcitonin, absolutely separate, they don't have anything to do with the lumen. They go directly into blood vessels, okay? So that's important for you to know. The other thing is that of these two hormones, more of T4 is actually produced, but that T4 gets converted into T3 at the tissue level. And why? Because T3 is the more active of the hormones. So T3 is the more active of the hormones. So even though more T4 is produced, it gets converted to T3 because it removes one tyrosine molecule, and it's the more active of the hormones. This gland produces a lot, the thyroid gland produces a lot of this hormone, and it can be stored for quite some time. This is under negative feedback, and we saw in that previous picture, a previous slide, TRH causes TSH release and then acts on the thyroid to produce the thyroid hormone. So calcitonin is not under that TRH, TSH pathway, okay? It's only these, because these are those thyroid hormones. So let's look at the actions of thyroid hormones. It acts on almost all tissues of the body. Basic action is to increase the basal metabolic rate. So when it increases the metabolic rate, when your metabolism increases, automatically heat is produced. So your body temperature goes up. And that's why we say it has what is called a calorigenic effect. That means increase your temperature. The very fact that you guys are sitting in this classroom, alert, normally, your temperature is all normal. I mean, you're not couch potatoes and you're not feeling lethargic. And yeah, okay, on a rainy day we might all feel lethargic. But as a normal, you're not feeling lethargic, and it's not, you can do a lot of things. That is because of your thyroid hormones. So if your thyroid hormones were not there, they say we would all be couch potatoes. And they literally mean couch potatoes, meaning you wouldn't get up at all. Okay? It regulates, like I said, tissues, affects all systems. So it causes, important for skeletal growth, important for muscular growth, important for brain development, important for all tissue growth. It also is important in the metabolism of the three basic nutrients. Glucose metabolism mobilizes fats, protein metabolism causes protein synthesis. That's how it helps in skeletal and muscular growth. All tissues. It also helps with blood pressure, because it makes your receptors on your blood vessels, makes the receptors more sensitive to epinephrine and norepinephrine. And since it acts on all systems, it also acts on the cardiac tissue, cardiac muscle. So it maintains cardiac function as well. So you can see it has a general effect on all over the body, just to make sure that you're growing normally, and then after you've kind of reached your full growth, you continue your normal activities. Everything goes on normally, your body temperature is maintained, blood pressure is maintained, all of that. The synthesis of thyroid hormones. Remember I said that it's important that you take iodine. So iodine is very important. So here it's showing you a follicle. So these are the follicular cells. So if you take just one area, so here is a blood vessel close by. Here is one of the follicular cells, and here's the lumen of the follicle. Okay, so we've just taken this one area. So this is the follicle, this is the lumen of the follicle, these are the cells. So I've taken one cell, a blood vessel close by, and the follicle here. So iodine, which you take in your diet, goes into the bloodstream, gets into the cell, and here this iodine is, so we call that trapping by the cell. And from an iodide, it gets converted to iodine, and this is thrown into the lumen. So iodide which goes into your cell, taken by the cell, converted into iodine and thrown into the lumen. Meanwhile, in the cell itself, the cell produces a particular kind of protein which is known as thyroglobulin. So the cell produces a protein which is called thyroglobulin, which has an amino acid in it called tyrosine. So the cell also produces that protein called thyroglobulin and throws it into the lumen. So you have iodine thrown into the lumen, and you have this thyroglobulin thrown into the lumen. So inside the lumen, that iodinated thyroglobulin is known as colloid. The iodine combines with that thyroglobulin, it combines with tyrosine molecules in that thyroglobulin. So when one iodine molecule combines in it, it's called monoiodotyrosine. When two, it's called diiodotyrosine. When one di and one mono combine, you get T3. When two diiodo combine, you get T4. Do you understand? The reason is because the cell here cannot take iodine and combine it with tyrosine within the cell. It has to go through this complicated route that combination of iodine to the tyrosine only occurs in the follicle. So iodine is taken separately, thrown into the follicle. The follicular cells themselves make up this thyroglobulin, a protein molecule which has tyrosine in it, throws that into the lumen. In the lumen, the iodine combines with that tyrosine, produces mono or diiodotyrosine. When one di and one mono combine, you get T3. When two di combine, you get T4. So now you have T3 and T4, which you can see, which are produced inside the lumen. They are then sucked back into the cell. So by endocytosis, they go back into the cell. And in the cell, this excess, the lysosomes remove this excess all of the rest of the thyroglobulin, and then T3 and T4 are pushed into the bloodstream. So do you see this complicated route that it takes to get to form T3 and T4? And in order to form that, iodine is important, which is why iodine is very important in your diet. And in certain parts of the country, earlier on, now we have iodinated salt, but in certain parts of the country, they used to call this the goiter belt. When people did not have enough iodine in their diet, they would end up with a condition known as goiter. So let's see if you can tell. What do you think is the problem with this person? It's a radiographic study, okay. Heart is enlarged. Okay, good. So you're looking carefully. Anything else? Yeah. There's a little gorilla up there in his lung. That's it. So just making you look at the images carefully. Okay. So we did thyroid. So here's a review of the thyroid gland, and it's very important for you to know the various hormones that take part in the feedback loop. Remember, thyroid hormones was one of those which was under hormonal control. So whenever there is low blood levels of T3 and T4, that stimulates the release of thyrotropic hormone from the hypothalamus, thyrotropic releasing hormone from the hypothalamus, which goes to the anterior pituitary, causes thyroid stimulating hormone, which goes to the thyroid follicles, and those follicular cells they make T3 and T4, and they release it into the blood. And remember, iodine was extremely important for this, okay? So again, just to review this loop.
Within the base of the forebrain is the hypothalamus, a region of the brain that integrates information from the rest of the body and regulates most of the body's endocrine systems. An example of an endocrine system regulated by the hypothalamus is the hypothalamo-pituitary axis. Some neurons within the hypothalamus produce and secrete thyrotropin-releasing hormone, TRH. TRH is secreted into the hypothalamo-hypophyseal portal vessels and carried into the anterior lobe of the pituitary gland, where it stimulates cells that make thyroid-stimulating hormone, TSH. TRH stimulates the release of TSH from the anterior lobe of the pituitary. TSH enters the bloodstream and is carried to the thyroid gland. At the thyroid gland, TSH stimulates the production and release of thyroxine, a hormone that regulates the metabolic rate of all the cells in the body. In addition to regulating our metabolic rate, thyroxine inhibits the TRH-containing neurons within the hypothalamus. This inhibition results in decreased release of TRH, and thus a decrease in secretion of TSH and thyroxine. This is called a negative feedback loop, and occurs frequently in the endocrine system.
The next hormone which is produced by the thyroid gland, and we don't call this a thyroid hormone. This is produced by different cells. Those cells are known as parafollicular cells. So they lie by the side of the follicle, so it's called parafollicular. Para meaning by the side of. These cells do not need iodine for production, hence the hormone is not released into the lumen of the follicle, so it's not part of the colloid. Instead, it goes directly into the bloodstream. And that hormone which is produced is calcitonin. It is responsible for calcium metabolism. What it does is it puts calcium into bones, so it makes your bones more dense. The stimulus for secretion therefore will be if there is high serum calcium, because the function of this hormone is to push calcium into bone and therefore reduce blood or serum calcium. So it causes reduction in serum calcium. So obviously its stimulus would be something opposite. So whenever there is high serum calcium, you want to bring that calcium level down, so the parafollicular cells will be stimulated. They will take that serum calcium, push it into bone, and hence blood calcium levels will come down. So it has what is called a bone sparing action. The other thing it does is, if you remember from ANP1, osteoclasts are cells which remove bone. They cause resorption of bone. So when they remove bone, they remove calcium from the bone and they throw that calcium into the bloodstream. So osteoclasts, in effect, would increase serum calcium. So this does the opposite. It inhibits osteoclastic activity so that serum calcium levels are not increased. Hence, you can see, since it makes bone extremely dense, it would be a drug that you might want to use in osteoporosis. Osteoporosis is a condition where bone density becomes low, so bones become very brittle. So, in fact, actually, they use a kind of synthetic calcitonin called miacalcin. So miacalcin is something that is used in some cases of osteoporosis so that you have this bone sparing action. You deposit calcium into bone. So that's how it helps. Its actions, therefore, you can see, even though it's produced by the thyroid gland, are entirely different from the thyroid hormones, T3 and T4. Let's look at some clinical conditions. So when we have hyposecretion of thyroid hormones, and again, I keep saying this, when I say thyroid hormones, I mean T3 and T4. When there is hyposecretion of thyroid hormones, in adults, the condition is known as mixed edema. Children, the condition is known as cretinism. And this is showing a child with cretinism. Since thyroid hormones affect all cells of the body, in a child, remember thyroid hormones were important for nervous system development, for muscular development, skeletal development. So you can see that this child is short-statured. Looks, if you look at the face doesn't kind of look very sharp, so there is a bit of mental retardation in such children, very, very lethargic. They don't grow well, so that's why, they're short. And adults, because growth and everything has already occurred, so it's not going to do anything with your brain development or your musculoskeletal development, but because your basal metabolism will decrease, what will happen is your body temperature would come down. These people would be very sensitive to cold because they're not producing too much heat. Their body is not metabolizing as much as it normally should. So they're very, very sensitive to cold. In temperatures which other people are fairly comfortable with, these people will feel cold. They also are extremely lethargic, again, because basal metabolism is low. This is one of the conditions which you can actually diagnose by the way a patient walks or even talks on the phone, because you almost wait to complete their sentence for them because they talk so slowly, and when they walk, if you normally take 10 steps to cross a room, they might take double or even triple the amount because they feel so lethargic. So that's what is seen in mixed edema, and you can understand why, because on the basis of what the function of the hormone is. The reason it's called mixed edema is because in this condition there is a jelly-like fluid called myxomatous fluid or myxomatous tissue. It's kind of jelly-like, and this is deposited in certain areas of the body. Some of the areas it's deposited is in the carpal tunnel. So a person with mixed edema might present with carpal tunnel syndrome because the carpal tunnel present at your wrist is a very narrow space, and you have the median nerve and lots of tendons passing through that. So already there is a traffic jam there. So you add some more tissue there, you make it even more tight. And so then the median nerve gets compressed. So this person, one of the presenting symptoms could be carpal tunnel syndrome. So, you know, you've got to kind of think of other things here. And on the anterior surface of the tibia, this tissue, myxomatous tissue is deposited. So if you press on the anterior surface of the tibia, there's a pitting edema. That means, you know, you form a little pit inside because of edema. So that's why this is called myxedema. Another condition where you have hyposecretion, and this is an autoimmune condition. This is called Hashimoto's thyroiditis. So autoimmune, presenting with same symptoms. And then the opposite of hyposecretion is a condition where you have hypersecretion of thyroid hormones. One such case of hypersecretion is a condition called Graves' disease. Graves' disease is also autoimmune, where antibodies which resemble, so antibodies resembling thyroid stimulating hormone are produced. So since these antibodies resemble thyroid stimulating hormone, but they are not thyroid stimulating hormone, so they don't come under that feedback loop. So what the result, they keep stimulating the thyroid gland. With the result, the gland keeps producing more T3 and T4. So there's increased levels. So what are some of the things you think such a person will present with? Very good. Fast heart rate, because again, basal BMR increases. Okay. And the person is very, yes, they lose weight, because if your basal metabolism is high, then automatically you don't put on weight, right? You'll tend to lose weight. These people also may have hypertension. It's possible they may have hypertension because remember, I said thyroid hormones make the blood vessels more sensitive to epinephrine and norepinephrine. They feel extremely warm. If your basal metabolism is high, then you tend to feel warm. So a lot of sweating occurs to feel extremely warm. And they may, in Graves' disease and in hyperthyroidism, one of the things that is seen is a condition where the eyeballs tend to protrude. That is known as exophthalmos. Ophthalmos is to do with eye, ex meaning out. So eyeballs protrude. In Graves' disease, this is thought to be due to, because of the autoimmunity and there's inflammation in the body, there's inflammation along the orbital tissue, the muscles swell, and the orbital fat increases, so that kind of tends to push the eyeballs out. Okay, so this is one of those things that you see in hyperthyroidism. So you can see here exophthalmos. So these are some of the things that you will see in Graves' disease. This is showing you a picture of a lady who has goiter. And goiter is usually when there is hypothyroidism. Because whenever there is hypothyroidism, that means the levels of T3 and T4 are less. What will happen? TSH levels will be high. So T3, T4 is less. So that negative feedback will not work. So TSH levels will be high. If thyroid stimulating hormone levels are high, it is going to constantly stimulate the thyroid gland to make it produce more T3 and T4. So then the gland enlarges. And when people have an iodine deficient diet, the gland enlarges even more because the gland is trying to make use of whatever little iodine there is, you know, try and stimulate the follicular cells, produce as much T3 and T4. So goiters were present, as I mentioned earlier, in many countries you have these goitrogenic belts. In the US too, many years ago you had a belt, and I think I don't know if I'm correct, but I think the Midwest was one of those goitrogenic belts where they found iodine was less, so people started having that. And then, you know, this was long back. Now that belt doesn't exist. So that need for iodine is very important to produce that, because if you don't have enough iodine, you can't produce the hormones. The hormone levels are low, which means TSH levels go up, and it constantly stimulates the gland, and then the gland gets really, really large. So let's review some of these. So let's look at some of these questions. Which of these hormones will not be found in the lumen of the thyroid follicle? Calcitonin, yes, you do find T3 and T4. Remember, they were made in the lumen and then brought back into the cell and then goes into the bloodstream. Calcitonin just goes directly from the cells into the bloodstream, doesn't need to go into the lumen. Okay, so Tiffany has not been taking iodine in her diet, and what is this likely to cause? All of the above, yes. She doesn't take iodine. She can't produce enough thyroid hormones because it's needed, which means it cannot negatively feed back on that TRH, TSH loop. So the increased production of TSH, which will keep stimulating a gland, and the gland will enlarge. So it will be all of the above. Okay. An easy one. Why do you think someone with hyperthyroidism would feel warm? Yes, their BMR is high. It just so happens that with hyperthyroidism, you will have all of these also. But that's not the reason why they feel warm. They feel warm because the BMR is high. Since they are feeling warm and their body temperatures increase, the blood vessels will be dilated. The skin blood vessels will be dilated to radiate heat and get rid or bring your temperature down. They will sweat because their body temperature is high. So again, to bring your temperature down. And they have high blood pressure because the receptors in the blood vessels are just more sensitive to epinephrine and norepinephrine. Okay, here, why do you think a child suffering from cretinism will have these signs? Both, because thyroid affects all tissues of the body. So musculoskeletal, nervous system development is not good. So that's why both of them will be affected, which is why they have mental retardation, short stature, and all the other signs. Okay, let's look at the other gland, the parathyroid gland. The word para would mean by the side of, but actually the parathyroid gland is not by the side of the thyroid. It's sitting on the posterior aspect of the thyroid. So this is, you're looking at the posterior aspect of the pharynx and the trachea and the thyroid cartilage, and this gland is kind of envelopes the thyroid, the trachea in front, on the sides, and a bit posteriorly. So you're looking at the posterior aspect. And there are 4 parathyroid glands. Usually you can have more than 4, 2 on each side. So they are on the posterior aspect. They also have something to do with calcium metabolism. And they are antagonists of calcitonin. So they do exactly the opposite of what calcitonin does. So calcitonin decreases serum calcium and pushes the calcium into bones. This gland, which produces a hormone called parathormone, so the parathyroid gland produces a hormone called parathormone or parathyroid hormone, parathormone or parathyroid hormone, so usually written as PTH. its function is to increase serum calcium. So it's exactly the opposite. So therefore, this hormone will be released when the serum calcium levels are low. So the stimulus is decreased serum calcium. So if calcium levels are low, you obviously want to produce a hormone which is going to increase calcium levels, and that's this one. And how does it increase serum calcium? So it's going to do exactly the opposite of what calcitonin did, right? So you're going to want to remove calcium from bones. You also want to absorb more calcium because calcium gets absorbed in the kidneys and GI tract. You want to absorb more calcium and push it into the vascular system. So it promotes osteoclastic activity, so bone resorption is more. And if bone resorption is more, what do you think this will cause? This could lead to? Exactly. This could lead to osteoporosis. So if you have high parathormone levels, you could have osteoporosis because it's going to cause more bone resorption. So osteoclastic activity increases, calcium is removed from bone, pushed into the blood. It also causes increased reabsorption of calcium from the kidneys. And it does this by activating vitamin D. Vitamin D is very important for reabsorption of calcium, which is why if you look at, when you go and buy to the drugstore, you'll usually see that calcium and D3 are combined together because you need D3 for absorption of calcium from the kidney, reabsorption from the kidneys. And it also causes increased absorption of calcium from the intestine. So everything it does to get calcium and push it into bone, okay? This is one of the reasons why you also might think, because if there's someone has a tumor of the parathyroid gland, and too much parathyroid hormone is produced, how do you think it could affect the kidneys? What is something that could happen in the kidneys? Yes. Very good. Yes, you could have kidney stones. If you're absorbing so much calcium from the kidneys, you could end up with kidney stones, and that's one of the side effects or one of the symptoms that you see when someone has a parathyroid tumor. Good job. So let's look at some clinical conditions. Hyperparathyroidism, as I just mentioned, because bones become very brittle, they soften, they could fracture easily. Kidney stones, as you can see. The opposite condition, if you have less serum calcium because of low production of parathyroid hormone, and you have that's hypoparathyroidism, you end up with a condition called tetany. This is different from tetanus, which is due to a bacteria. Tetany is when the nerves get hyperexcitable and they start twitching and you have convulsions, and the muscles also become hyperexcitable at the neuromuscular junction. And so you could go into respiratory, what is called stridor, like you could have problems. They would fail to be able to breathe properly. So here's something which is seen when somebody has tetany.
Okay, this is your positive chopstick sign.
So see this facial twitching which occurs, just a light tap on a person's face, even the fingers kind of tend to, normally if you tap your face you're not going to twitch. A light tapping, because muscles get hyperexcitable along with the nerves. So there's, can you see the twitching that's going on in that? So this is because of that hyperexcitability. So let's look at these two hormones together, calcitonin and parathormone. So if there's high level of calcium in the blood, it will stimulate the parafollicular cells of the thyroid gland, which will release calcitonin. This promotes deposition of that calcium into bone matrix, which decreases serum calcium or blood calcium. When we use the word serum calcium, it's the same as blood, because serum is nothing but coagulated blood from which some proteins have been removed. Okay, plasma from which some proteins have been removed. If your blood calcium levels fall really, really low, then that low level will stimulate the parathyroid gland, which will produce parathormone, which will cause release of calcium from bone. You'll lose less calcium in the urine. It'll increase, which the end result of which will be increasing blood calcium. It also promotes the kidney to activate vitamin D, so D becomes D3, and that causes absorption of calcium from the gastrointestinal tract that goes into the bloodstream, and your blood calcium levels go. So you can see both of them are acting together with antagonistic actions. So at all times your calcium levels are kept normal. Okay? So let's review this. Which of the following would cause parathormone to be secreted? Here, okay, sorry, you're correct. I was thinking about calcitonin. You're right. Decrease serum calcium levels, because if you think of what is the action of parathormone is to increase serum calcium. So obviously the opposite would be what would cause secretion of parathormone.